let's talk about other new approaches. So we've got a lot of new agents out there. There's combinations of looking at checkpoint inhibitors with antibodies and with obinutuzumab and lenalidomide. Let's start there. So Nathan, you've done a lot of work obviously with the R squared. Now we're talking, and I think you also you have data with obinutuzumab. So how about with the atezolizumab, using 3 agents?
It's a very interesting concept with atezolizumab, which is a checkpoint inhibitor. We had hoped, or I guess the hypothesis is that you can further augment the immune response. Again, you give it with lenalidomide, which is an immune modulator, and an antibody. We could create this kind of perfect storm that attacks the follicular lymphoma. There were studies combining checkpoint inhibitors with lenalidomide in myeloma that unfortunately showed excess mortality. And so I think that, that triplet, at least in lymphoma, we've been very cautious proceeding with atezolizumab or any of the other checkpoint inhibitors combined with lenalidomide because of the worry of excess immune flare or excess toxicity, infections, etc. There was an abstract by Gilles Saul at this meeting where they combined atezo with obinutuzumab and lenalidomide. And I looked at this yesterday. I was looking very carefully. Not a lot of itises, so they didn't report any pneumonitis or hepatitis or colitis. Now there was adverse event rate, which was around 80%, grade 3, or I think it was around 70 or 80% grade 3 or higher, but it didn't appear that those were immune mediated. So maybe it's something we could look at further. But at least in the myeloma setting, there were unexpected toxicities which halted that triplet. So combining lenalidomide with other antibodies also looks to be, could be a very interesting concept. We now have data with lenalidomide and obinutuzumab. My colleague Loretta Nastapil presented that data, and at this ASH, Frank Morchauser is presenting lenalidomide, obinutuzumab in frontline follicular lymphoma, 100 patients, and it looks quite interesting. We also have seen lenalidomide combine with anti-CD19 agents, both in follicular and in large cell lymphoma, presented by Gilles Saul, which also looks really intriguing, especially, again, in these kind of hard-to-treat patients. So I do think there are other combinations we could look at with lenalidomide. I'm waiting a little bit for the checkpoint inhibitors, but monoclonal antibodies, I think, are wide open.
Other monoclonal antibodies, polatuzumab, antibody drug conjugate, it's fairly advanced in development. Scott, what do you think of this data?
Yeah, I think the data is most mature in refractory large cell lymphoma, and I think it looks encouraging when combined with bendamustine or rituximab. It seems to be safe. It seems to improve overall response rate and certainly durability or PFS. I think it's likely to move up with follicular in terms of combination therapy as well. There's some trials that are exciting combining that with, say, venetoclax or obinutuzumab. So I think POLA will likely find its way to follicular lymphoma as well.
Yeah, I guess there was some of the initial studies with higher doses and more prolonged use. There's issues with neuropathy, but in the subsequently dose reducing and limiting how many cycles you give, that seems like the adverse event profile is a lot better. Are you using CAR T cells? You have trials with CAR T cells available at?
We have trials. I think we're obviously excited about this modality. The approvals are in aggressive B-cell lymphomas, but the data, very early anecdotal data, suggests that the response rates might be even higher in indolent histologies. I suspect this will be something else in our armamentarium over the years. This will come and be available. I think we'll need to be sure that we're doing it in the right patients. The risk is considerably higher than anything we've talked about so far, except for maybe allotransplant. So we want to make sure that this is applied in the proper patient population, keeping in mind that 80% will have a normal lifespan. But certainly there's some very exciting early data.
Yeah, I think that's you brought up a really important part, and it gets all back to sequencing that we've discussed. It's like when do you pull the trigger on something that it may have awesome results, but could come with a substantial toxicity. I guess the thing that I worry most about is the neurotoxicity, the cytokine release. We can usually manage. Nathan, I want to ask you one more thing. So I think your colleague Loretta Nesbitt also has data with Pembro and rituximab, a checkpoint inhibitor without lenalidomide, and
the data looks good. This was in relapsed patients, and we saw a response rate around 80%, and the CR rate was, I want to say, right in around 50%. It's hard to know. The problem with studies where you're using rituximab as a partner, it's hard to know the contribution of rituximab versus pembrolizumab. That response rate is a bit higher than we would expect with single agent rituximab, and the CR rate was higher, but I think it will kind of require other studies to truly understand what the contribution of pembrolizumab. Unfortunately, pembrolizumab as a single agent, and this was presented, I think, at ASCO, 9% response rate in follicular. So as a single agent, checkpoint inhibitors have been a bit underwhelming in the low-grade lymphomas. Maybe combining with rituximab, again, augmenting ADCC could be the way to move forward, but I think it requires larger trials.
I thought there was some. I mean, I read the data, and I guess I thought that was interesting, but I also worried a little bit about the adverse events, right? I mean, there were some checkpoint inhibitor problems. It's not just giving, water.
We have seen some couple cases of pneumonitis and inflammation that we would not expect to see with rituximab as a single agent. So there clearly, I think, was some additional toxicity adding a checkpoint.
And clearly, a person in need, the right patient, that you may be willing to take that adverse event, but not for everybody.
Right. We're actually doing a confirmatory trial at our center with rituximab pembrolizumab to see if we can, in rituximab refractory patients, to see what data we get. And we're also looking as a window study with single agent pembrolizumab in the frontline setting for high-risk follicular, with the idea that they have a replete immune system, and you actually might see the ceiling of the response rate, but we're very selected patients for that.
Right.
I think there's some interesting data on intratumoral injections as well, combined with checkpoint inhibitors, and in a select population, intratumoral radiation checkpoint may lead to some durable responses, and so from Stanford group and Sinai group. So it's an exciting time. There are certainly lots of things that we combine. I think the trials need to be well developed and rational, and I think we're moving the field forward, certainly.